Good.
Hello, and welcome to this week's program of the Rotary eClub of Silicon Valley. Each week, we connect with and hear from fascinating and inspirational speakers, often with a message focused on our interests in innovation, entrepreneurship, and education. My name is Farheen, and I thank you for joining us today. This week, we have my Medical Director Jim Gude and President Michael Cook of Global OffSite Care. This organization is a consultative telemedicine platform and provides weekly continuing medical education to the developing world. And with that, Jim, Michael, please take it away.
All right. Let's see. We'll launch the PowerPoint momentarily. But Jim, why don't you give them the overview? Let's see what happened here. Oh, I know what's going on. Never mind. Voila. So we're still visible here, but there's your slide. So might as well start by saying the mission of Global Offside Care is to promote Rotary Club-sponsored telemedicine projects by bringing together financing and stewardship and advocacy among Rotarians with the medical expertise available through Dr. Jim Gude. So we're sort of the middleman, and we've been promoting it for a while. Let's see, I'm going to go to, So there's three key features of what we offer. One is continuing medical education in weekly 1-hour sessions for medical professionals, primarily doctors, and that includes everyone in the Western Hemisphere, including the Caribbean, and we include Africa in the West, as opposed to Asia. So we do separate sessions for Asia once a month. In fact, our next session is today in a couple of hours after we get done here. So that's one of our key offerings, and it turned out to be very popular because education's hard to get once you graduated and you're now working as a doctor. And in the developing world, travel is more challenging than a lot of places. It's dangerous and expensive and difficult. So having continuing medical education available where you work is a big plus. Another thing we offer is teleconsults. So if you are a doctor in Nigeria and you have a patient and you've tried a couple of procedures and they're not working, you wonder what it is and you want senior medical advice, then you can contact Dr. Gude, who's our triage officer. And if it's within his sphere of expertise, he can provide direct advice or bring in one of his colleagues. We have about 12 that have offered their expertise, and we've got more actually available. Dr. Gude has a lot of connections, it turns out. And the third item that we offer is electronic medical records. And Dr. Gude helped develop, or actually started developing an electronic medical record system focusing on the clinical aspect. And he became partners with someone who had a business background and expertise in software development, and they've been expanded on this system and helped track the business side of working with patients. And this is primarily aimed at hospitals. So we are now offering that system, and there's an introductory phase, and then it's designed to be low cost. So that's the third element of what we offer, and it makes the other two aspects more efficient. If you want to teleconsult, then you can easily access the or make available the patient's data. That's going to make for a more productive consult. And it turns out the continuing medical education sessions are focused really on recently seen patients. So having actual patient data available after it's depersonalized and that, or we have written permission to share it, then we can use the electronic medical record collected data to help with keeping doctors' skills and expertise up to speed.
Can I make a comment, Mike?
Yeah.
First of all, Jim Gude, and I'm a intensivist and pulmonary doctor. I'm a professor at the University of California in San Francisco. And I love this concept of telemedicine. Let me tell you why. If you look at that slide and you look at continuing medical education, consultations via the internet using different platforms, we've got a very cheap platform, electronic medical record. We've got an electronic medical record that is, you can usually do it for, 50 cents a chart per month, that type of thing. No one else can do anything like that. You look at those three components, and now imagine 30,000 Rotary clubs. And let's say a portion of those Rotary clubs, let's say 2,000 of them, decided they wanted to help a local, needy, deserving hospital, and they would, by bringing these elements to that hospital, increase the ability to practice best medicine, or even more than 2,000. Let's say we have more than that. This is really a way of reaching out in the world with Rotary clubs anywhere to any local hospital, and they can adopt this as a project. It probably runs about $6,000. For a project, that's very reasonable. And Mike will go over the things that includes, but it includes, an electronic board, a microphone for conferences, a little Kubi device that we can put an Android pad in for consultations. And it can include also an electronic medical record that's cloud-based. And we intend to do one free one in each country and then others at a nominal fee, so this thing entrepreneurially stays alive. But the key here, and this is a very big comment, is to improve world health. If this got to be the proper size, you would have many hospitals improved by a local Rotary club with a formula, with instruments, with equipment, with protocols, with electronic medical record that will keep histories and almost think for you in terms of providing plans and protocols and so on. So as a physician, this enables me to reach large in the world as opposed to small in my practice. Practice can involve 1,000 people or 1,500 people, something like that. We're talking about a project here that with Rotary connections can get to be a very big project. And we actually have strategies how to take this to a big level. And we'll comment on those later on.
Yeah, this is an illustration here of a remote session that we did not long ago, and it shows you what you're looking at on the right, and then this gives you an idea of the audience that can be there. Sometimes the audience is small, just 3 or 4 doctors, but often we have a bigger contingency overseas. And this, Dr. Gude mentioned the Kubi. This it's called a Telepresence Robot, and that's a normal tablet in that Kubi, and it can be manipulated by a remote doctor, so he can interact better with the patient, and nobody has to stand there and hold it, and it facilitates the communication. So we've been doing this for about 5 years, and this is a graphic illustration of where our projects are now. This is more of a list, and it shows we have several locations in Africa and Asia, and we're beginning to expand in our own hemisphere. We're trying to overcome the language barrier because the Spanish-speaking countries are more challenging for us because we don't have presenters that can work in Spanish. But in Asia and Africa, English is the second or third language of most of the healthcare professionals, so it becomes feasible to go ahead and communicate primarily in English, which is what we do. And this graphic kind of captures that middleman status of what is global offsite care itself. This is just a group of Rotarians that see the potential of Rotary clubs getting involved and bringing telemedicine to a nearby hospital and connecting through medical professionals who are interested in doing work on a humanitarian basis. At least that's how we started. So diving a little deeper on us, we're a 501c3, which means something to the people in the United States because it's a tax status. And we really wanted to expand the group instead of having it be the project of a single Rotary club. So we put together a board of directors that has people from several Rotary clubs to help guide the project, and including Princess Kamala from Nigeria, who is a doctor and a Rotarian and a leader of a project in Nigeria. So we have recipients also with a voice and able to help guide what we do. At this point, it's an all-volunteer humanitarian nonprofit. We find somebody with deep pockets, we'll hire somebody to up the level of consistent effort. But so far, we've been doing all right with the all-volunteer staff. We currently have 12 projects in 11 countries, and we're working hard to expand that network. And the way I see it is kind of working out with, towards building a network of peers. So it isn't all necessarily the expertise is in the US or some developed country. Okay, so global offsite care will be growing, and we have plans for how to grow. And this is sort of for the immediate future. We are looking to offer accredited CME units, which are continuing medical education units, through the weekly sessions that we now offer on a free basis. And it costs money to do the accredited thing, but it's one fee. And so more people joining in and receiving the accredited units doesn't cost more. So that's great. It's very scalable once you've paid that base fee. So we started that on a pilot basis. Now we want to cover every grand round session we do. So we're out looking for partners to do that. We're also, we have 2 projects right now in Nepal, and we're putting together a vocational training team grant so that we can bring people from Nepal to California for more intensive training in the techniques of telemedicine, and also to see how telemedicine is done here. And then they'll go back to Nepal and expand the network there. So we're pulling that together. We've approached several clubs. We have several who have contributed or pledged to contribute to that, and we're looking for more. So that we expect to happen in this Rotary year. We also have a project in India, northern part of India, and our project lead there has said, you know, he has a very small facility, and he said, we need to be having bigger institutions benefit from this project. So he approached a medical school that's launched near his project, and we anticipate having a project launch for that in December of this year. We're actively working on EMR system, and that's the electronic medical record systems that have been offered in Uganda, Rwanda, the Congo, and Nigeria. So Uganda is the leader of the parade on this, but everybody is working on it, and we expect to see the system adopted and implemented I think it's within 6 to 12 months.
I think if we tried it in 3 months, we'd have to try it up and running in Kabali. We're talking. I was talking to Dr. Bikinyagi in Kampala this morning.
Okay.
I called Dan Smith. I think we're going to try to do it.
That's great. So, as a computer guy, you know that when you're almost there, you're not really almost there. But we'll get it done, and we've got the people underway to implement that.
I can add something about partnering. You know, when we talk about education, we do this with them, not for them. For example, on Wednesday, we had grand rounds presented from Nigeria on the topic of tuberculosis in a 5-year-old child with sickle cell disease. It's very unusual for sicklers to get tuberculosis. They're protected. There's a protective mechanism I won't get into, but it's very interesting. If you're a sickler, sickle cell disease, you're protected against malaria and you're protected against tuberculosis. So there are advantages to things. Someone asked me the advantages of diabetes the other day. I said, there is a distinct advantage. Diabetics are smarter. They are.
Right.
They are.
They're doing all the math. I mean,
No, it has to do with, there's a guy by the name of Dr. Lederberg who got a Nobel Prize, and his topic at Stanford was, what's good about diabetes? And he pointed out, he proved, the intellects are higher. Anyway,
you'd think I'd go with being a little
Excuse me,
dumber.
gentlemen.
but it's interesting that the other side of things, like that,
Yes.
you know, they really are. But we
Excuse
do
me, gentlemen.
with you folks, what we're doing.
Excuse
Okay.
me.
Yes.
Excuse me.
Yes.
We have a problem.
What
what
is it?
What happened was that I got onto my screen and noticed that Skype worked with Microsoft, and it bounced me out of Zoom.
because I'm actually recording right now. I started recording after you logged off. So did you get the beginning recording?
Yes, I did.
Okay, then we're okay. I can just splice the videos together, so no problem.
Okay, great.
Okay,
Okay.
so let's continue. Sorry about that.
Well, we're at the end of the slides that we put together, and they've got contact information here, mostly through our website. We've got ways to sign up for our newsletter. They can also email us directly. So what questions do you have?
Great. Wow. Thank you so much for your wonderful presentation. Using technology to help the underserved population. That's so incredible. So yeah, does anyone, I mean, I have a lot of questions, but Cecilia or Roger, do you want to start out?
Go ahead, Cecilia.
Well, yes, actually, I probably have a lot of questions as well, but I'm just curious whether you are, either of you know Dr. Jack Higgins, who is here in the Bay Area.
No.
He's a Rotarian in Los Altos, and he's actually been working on a telemedicine program of his own for some time, and it might be good to connect the two of you. And the club that he is in, the Rotary Club of Los Altos, is actually equipping and training personnel in 16 birthing centers in far northeastern Nepal, which is very challenging, as you probably know, because the infrastructure is so poor there. And so it sounds like there's kind of some crossover work between what you're doing and what they're doing, and might be worth at least investigating the idea of whether your efforts could work better jointly than they do individually.
Yeah. Great. Can you send us the contact information for him?
I will do that.
We'll contact him.
That's great.
Thank you.
Roger?
Yeah.
First question that I have is, what technology programs are you for your for within your operation?
Well, for communications, we use both GoToMeeting for our Africa sessions and the Western side, and for Asia, we use Zoom. We use kind of garden variety equipment like webcams, laptops, that sort of thing to be the platform, except for the Gude that we mentioned is the Telepresence Robot that enables a remote person to just use a standard tablet, but take it over remotely and pan and tilt so they can communicate more effectively. That's the only unique thing that we have. But other than that, we're using standard widely available technology.
I'll just comment, talk about our electronic medical record. It's called Harmony MD. And it really is revolutionary because it's so cheap. You know, the trouble with electronic medical records is for a hospital to get them, they cost millions of dollars to start. We literally have this thing to be as cheap as the paper of the hospital using it. That's our goal. And whatever they're spending in paper, we should be able to do it less with the electronic medical record. As you can imagine, we're not a big margin company. In fact, we have none almost. So what we are is providing a technology that is called blue ocean technology. No one else is doing what we're doing because they're all caught up in big profits. But what we're doing is we can really literally give this thing away very easily. And also people can subscribe to use it. And it's a very good electronic medical record. The hospital I work in, Sebastopol, the Snowwest Hospital, we run the hospital with this record. We've been doing it for a couple of years, doing everything. And there is nothing as cheap and reliable. Now, it doesn't have bells and whistles. It's very straightforward. It's like a chart with different sections of the chart, but it works and it's economical. And really, it's very interesting. The best technology is the cheapest because we're using concepts that are very easy to do, work well in electronic medical record, you know, pharmacy, drug interactions, allergies, history and physical, looking up things and so forth. For a good computer person, we can put this together modularly very, very well. In fact, this whole thing started, I was at a party, a cocktail party, and I met a fellow in the New York Times. And I said, you know, I'd really like to create a cheap electronic medical record. He said, well, I could do it. I could do it in my garage. I could do it with modules. It's not that hard to do. He did it. And he now is the medical director, he left the Times and works for us. But we have something that, you know, we're doing the normal things, which is consultations and education, but we're applying something which is the very best, cheapest technology that's our own, and we own it. So we can give it away. We don't want to give it away entirely. We want to make something on it so we can be entrepreneurial and proceed on this thing. For example, our current goal is to be the electronic medical record for the nation of Uganda. Something like that. It's pretty striking. And when it comes to offering proposals, no one can touch us. They have to leave the room because we're so cheap. Anyway, it's sort of fun for me to be in this type thing, the blending of entrepreneurship and technology. You know, trouble about medicine, usually we give them our worst technology, things we're throwing away. You know, we give them the machines we're not using anymore. We're giving them something that it really works great, and you can run a hospital with it, and it costs pennies. And it's going to change the medical field. It really is. So we're very excited about this thing, and we want to get this thing big. In fact, part of our strategy is to meet with the president of Rotary in December and try to get Rotary as a national organization to take this on as a project as big as polio. Because if you improve, you know, 20,000 hospitals in the world, you're going to improve medical care. And we deal just in the hospital. That's the unit we deal with. You have to pick what you're going to do. We're not the clinic. We're not the house, etc. We're the hospital. And that's sort of the purveyor of healthcare in the community. But what we're doing, to me as an old doctor, is very exciting. It really is.
In Canada, to give you an example, one pharmacy that I know of, what they do is they offer a service which is very similar to the difficulty in Canada is being able to see a doctor because of the shortage of doctors in our system. Therefore, what the pharmacy has done is that for a fee, then what happens is that you go to sit in front of a doctor, which is online, who does a diagnosis and of your problem and has the ability to write a prescription. All of the medical records in British Columbia are all online, so that with the so when a patient comes in, electronically you're able to then pull up that person's records, review them, and also to be able to diagnose the person that's sitting in the screen in front of you by the use of technology. That's already happening. And why it has developed this way is because there's a huge shortage of doctors in our system because of the, how can I put it? There's no political will to change the system, because the theory is that the more doctors that you have in the system, which then means that the healthcare costs go up. So by limiting the number of doctors in your system, you're able to control healthcare costs. So many people do not have family physicians. And as a result, innovatively, like this one pharmacist has come up with an alternative so that you can get medical help, and it's strictly online.
I mentioned I have my own company of telemedicine. I'm doing this technology I bring from my own company, all right? In our company, we go anywhere, in the United States, and if there is a lack of specialists, we will give those specialists by telemedicine. We'll give stroke, we'll give intensive care, we'll give dermatology, we'll give psychiatry. In other words, if it's not there and they want it, we can provide it. And the techniques are getting very good. For example, with a good resolution camera and so on, you can really see very well and so on, hear very well. You've got a stethoscope. The stethoscopes are working very well on the electronically. You can do ultrasound, which is actually better than a physical exam. You're actually looking at the interior, looking at the gallbladder, looking at gallstones, and so forth. So we can take a physician, arm him with these abilities to use technology to make a diagnosis. And it's very easy to do. For example, last night I was on call for a 20-bed ICU in Tennessee, in Clarksville, because they didn't have an intensivist who could work there last night. So I covered the ICU from 7 to 7. I admitted 3 people, had 1 death, but it was all done by telemedicine.
The other question that I have for you is that I know in Canada that the doctors have to fulfill a number of hours of continuing education every year. And is that not the same in the United States?
25 hours a year.
Right.
And you have to have that when you renew your license. You have to demonstrate proof that you've taken those hours and attend them and so on.
Yeah, it's very similar to Canada then. Where do you obtain your physicians to do the education?
Well, first of all, everybody's an equal. Remember, like the conference we had Wednesday, my teachers were from Nigeria. We had a Nigerian specialist in TB present a case of TB and a sickle cell disease. So we go, it's partnering, and each area has someone who's very good at something. And we try to bring them together. So I try to look about this as an even playing field. We're learning from them, they're learning from us. They know a lot about Rift Valley fever. I know very little. I know a lot about hyperlipidemia, more than they know. So, but together we pick topics so that the best person presents it. And if we're going to have a case, for example, presented of tuberculosis and HIV, that should be from Africa. They have much more than we have. They're much better than we are. we're going to have a case of Ebola presented. And by the way, this last year we had 2 cases of polio presented from Nigeria. Live cases presented to us in terms of our morning session. And that could be very important because polio, if vaccinations fell through, so it could spread again. So could smallpox and so forth. So our teachers are, any of the centers we're in who are expert. Now, I'm at the University of California and I can tap teachers there, but we don't want to have an educational system that speaks down to people. We want to be on an equal plane. So people are involved, and I encourage, like, I'm trying to get Rwanda to present rounds next Wednesday. A little hospital in Rwanda, the Shura Hospital, and so that type of thing. So we're really looking upon this as very egalitarian, and it's not the high-powered rounds that'll be given at Harvard Medical School. These are practical rounds of physicians who are trying to take care of patients, and we actually present patients, and we want these to be fresh and green, not old and graying, in terms of an approach. And it's very, you might say it's a commune way of teaching. We're all in the same commune, that type of thing.
Thank you.
Thank you so much. Cecilia, do you have any other questions? I have one that I want to quickly ask.
Not for now. Thank you.
Great. So my question is, how can I get involved? So like I hearing your presentation, like doing something like what you all do is not only just phenomenal and fantastic, it's one of my life goals to be able to help the underserved communities around the world, and specifically, and that's one of the reasons why I was doing my master's in Japan in reproductive biology, but I decided to come back and pursue medical school for that reason of wanting to make a greater impact. And again, I really want to go into gynecology and specifically practice to help the underserved kind of minority population of women who need that care and can't necessarily get it. So, but again, what you do is, it's phenomenal. And so I was wondering, like, how can someone like me get involved with your organization?
Give me a call.
Well, there is that. You said medical school.
We'll give it a
Yeah, but
I
as a
will call you. Yeah.
We'll get you. In fact, you could be head of the OBGYN section of India.
Thank you. I do speak Urdu. Well, so, and I was just, wanted to know, I looked at your website, but I didn't necessarily see much kind of social media. Are you involved with kind of Facebook or Twitter or things like that, or is that not what you've done?
We do have a Facebook page.
Uh-huh.
We could be freshening it more often, but that's something that we know we could do, and we haven't done as much as we want.
Well, if you need a communications director, you let me know. I'm really good at it.
All right.
Wow.
I would love that.
I have your email, so we'll
Yes.
start with that.
Perfect.
Yeah, that would be a great way to get involved, actually, because what we need is somebody who has some kind of medical background who can interview the participants, particularly in other countries, and get their story out about how they got involved and what they're getting out of their participation. That would be excellent. And that'd be fun, right?
Yeah.
Get to talk to these
Really
guys.
cool.
So that would be perfect.
How'd you like to be in our board?
Yes, please. No, I don't know if I'm ready for that, but no, I would love that.
Yeah, I understand.
Great.
Yeah, well, I appreciate your enthusiasm and your interest, and we'll follow up with you on that front.
Absolutely. Thank you so
But in
much.
general, I think one of the things you can do is look at the projects that we have as potential projects and say, my cousin or, people I know or like Filipino might love to be involved in supporting the Zamboanga City project, which is in the Philippines. There's a big expatriate community in the Bay Area. So we're thinking maybe there's a way to connect with those guys and raise the funds to do the project launch there.
I've got a daughter, Kate, who's in Los Gatos with her family. Is that nearby you?
Yeah, I'm in Santa Clara, so yeah, pretty close.
Why don't we talk?
I would love that. That would be awesome.
Send your information when I come down. Maybe we could meet and have a coffee in Los Gatos or somewhere.
Perfect. I mean, I can also drive up. It's a beautiful drive.
That's right. And we could take you to one of Dr. Gude's buddies runs a winery here.
Awesome.
You can get one of the fringe benefits of visiting up in Sonoma County.
Perfect.
You have other questions on global offsite care?
I think in the interest of time, since I don't want to take up too much of your time, I'm good, and that maybe, you know, again, after the end of this recording, maybe we can talk a little more. But Cecilia, Roger, do you have anything else? Oh, great. So before Jim and Michael give us their final words, I would like to encourage everyone watching to leave a comment below. Members and Rotarian guests, please make sure to fill out the attendance section. And as always, I would like to give the final words to our speakers.
Oh, Dr. Gude, you get the last word.
You want me to stand in for
You know, the last word would be this, that it's very inspiring to run across a young person such as yourself and some wisdom such as your colleagues can give us, because we benefit from, number one, your advice. And I think we do need public relations and someone who's good in Twitter, things like that. I'm certainly not. You know, I like to etch one mark in a stone a month. That's it, as opposed to too much. But I enjoy your comments. Help us grow and help us expand. So thank you for your interest. It helps us. Thank you.
Thank you so much.